Hello, ladies and gentlemen. Thank you for joining us today. I am Hideo Ichimura, a thoracic surgeon at the University of Tsukuba Hospital, and I will be chairing this session. The title of today's session is Cancer Treatment for the Elderly, Present Challenges and Future Vision in Aging and Super-Aged Society. First of all, I would like to open with an opening address by the President of the University of Tsukuba, Dr. Kyosuke Nagata. President Nagata, please take the podium.
Right. Good morning, everybody. In particular, the friends from Brazil. Welcome to the Tsukuba Conference 2023. As you know that this is the president of the University of Tsukuba. On behalf of the University of Tsukuba, I would like to extend heartfelt welcome to all of you, in particular again, people from the Brazil. Actually, the name, I'd like to deeply express that the gratitude is that as for Renato Ishikawa-san and Dr. Koshiro Nishikuni-san and Sandora Hiroko-san, Watanabe-san, and Ninomiya Sensei and all. And prior to this session, I would like to share that the outline of this conference. Tsukuba Conference is the international conference where, in particular, talented young people from all over the world in industry, governments, and academia gather in the Tsukuba Science City to discuss and make a network on various people and to solve the various issues. And it aims at the probably when I met at the World Economic Forum people, and they say that, oh, it's a sort of the young Davos meeting. Well, I completely agree. The main theme of the this year is that design the future. Design includes that not only planning, design to create, and the curiosity-driven quest for the global solution, which will bring together the curiosity and the imagination of young researchers to design, I say that, to create a new future and to solve the number of the issues, including, for example, CO2 emission or something else. And of course, this session is focusing on the issues on the medical area. And a title of this session is Cancer Treatment for the Elderly, Present Challenges and Future Vision in Aging and Super-Aged Society. And this session is also feature 6 presentations from the Santa Cruz Japanese Hospital and the University of Tsukuba Hospital. For several years, I mean that the Tsukuba University Tsukuba Hospital and Santa Cruz Japanese Hospital future an ongoing exchange in the field of medicine and medical treatment. In 2018, we were selected by the JST Sakura Science Program to receive the 9 doctors from Santa Cruz Japanese Hospital for 5-year training. Furthermore, this year, we invited 3 young doctors from the Santa Cruz Japanese Hospital for training. They will also join this session. I don't know exactly who it is, but share idea and answer they have generated during their training here. Despite impact of the COVID-19, 2 organizations have continued mutual interaction and through online seminar and so on. This year, we are able to finally host the face-to-face meeting with speakers and young researchers from Brazil. In the session, probably Dr. Hara is mentioned more, but briefly say that we are discussing about super aging society. And Japan is the leading country in terms of the aging populations. But many countries is following this situation, Brazil too, I guess. And also, this aging society brought us their cancer patient increasement. Yeah, because their lifespan is expanding, so that cancer patient is also increasing. So therefore, today's title is very reasonable: cancer treatment for the elderly. In addition, in addition to the recently developed new therapy, the elderly needs more to this one, because there some has some elderly specific symptom, so that we need not only their cancer therapy but also their care of these elderly people. So therefore, this is a very difficult questions that we are facing. And in this session, I hope you're discussing this matter and find some new aspect. That's my hope. And please enjoy this session. Thank you very much, and obrigado.
Thank you, President Nagata. Next, I would like to have another opening remarks by Dr. Akira Hara, Director of the University of Tsukuba Hospital. Dr. Hara, please take the podium.
Good morning. Good morning, everybody. I'm Professor Akira Hara, the Vice President of the University of Tsukuba and a Director of the University of Tsukuba Hospital. I'd like to express my gratitude of all of you who gathered here and joined for this session. Now, the concept of Tsukuba Conference is to bring together young researchers, engineers, entrepreneurs, and others who are active on the global stage in Tsukuba City. The goal is to share the knowledge about society and scientific technology and to explore solutions for global issues. And over 2023, we are facing urgent global challenges, medical issues. With your knowledge and curiosity as driving force on this platform, we hope to find the key to solving these issues. The main theme of this event is Design the Future Curiosity-Driven Quest for Global Solutions. It's harness your great curiosity and imagination to envision a new further together. In this session, we still address medical issues, medical practices, and the world have reached a highly advanced level. Among them, Japan's medical practices are the forefront globally, boasting an advanced medical technology, minimal invasive procedure, and robot-assisted surgeries. University of Tsukuba Hospital has a great leader in the field of medical research in Japan for nearly 50 years. Particularly in the field of cancer treatment, we are the only designated cancer care corporation hub. We prove cancer treatment through team-based medical care centered around patients and involving collaboration among various medical specialties. Currently, the leading cause in Japan is new neoplasm, and addressing the aging population is crucial in cancer care. Elderly cancer patients often have complications such as hypertension, stroke, heart disease, diabetes, and age-related functional impairment, requiring complex and advanced medical care. In both Japan, facing super age society, and Brazil approaching an aging society, we will discuss current challenges and further prospects from different perspectives. Speakers, audience members, and participants will collaborate to explore solutions. Additionally, trainees undergoing training at our university will also participate, sharing ideas and answers driven from their training experiences. During this session, 3 presentations will be given from Japanese side. Subsequently, 2 presentations will come from Brazil Santa Cruz Japanese Hospital. Furthermore, trainees undergoing training at a university hospital from Japanese hospital will also participate in the session and present. With the abundant curiosity as the driving force, we aim to discuss the medical issues we are facing and discover the future of healthcare and well-being. As Walt Disney once said, the special secret of making dreams come true can be summarized in 4 C's. They are curiosity, confidence, courage, and constancy. Let us also dream of our health in the future with today's curiosity and continue to interact with medical institutes around the world. I hope this will be a fruitful session. Thank you so much.
Thank you, Dr. Hara. Before starting the program, I would like to give some information to the presenters. The presenters have been informed in advance of the time for their presentation. Not being a chime and a buzzer during the presentation, so please be punctual, as I may ask presenters who are running over time to wrap up. We will not have an individual question and answer time for any presentation, but the Q&A session will be scheduled after all presentations are completed. So now let's get started. The first presenter is me. I'm going to take the podium. Hello again. I'm Hideo Ichimura. Today, I would like to talk about lung cancer surgery in the elderly. First, I will briefly introduce the epidemiology of lung cancer. Globally, lung cancer ranks the second in incidence and the first in mortality. Therefore, lung cancer is one of the global. The graph on the slide shows the crude incidence rate of lung cancer per 100,000 population for each age group in Japan. The incidence rate increases with age for both males and females. This data indicates that lung cancer is a cancer of the elderly. This table shows time trends of lung cancer surgery in Japan. Data were obtained from the Japanese Joint Committee of Lung Cancer Registry database since 1994. The number of patients has increased with each survey, and the mean age of the patient has been getting older. The percentage of patients over 80 years old exceeded 10% in the survey of 2010. In general, the key of surgical therapy for lung cancer is a balance between merit and demerit. Merits of surgery are cure of lung cancer and extension of survival period. The demerits are functional impairment and the symptoms associated with surgery such as pain, dyspnea, and fatigue. Then those result in QOL decline. Elderly patients often have multiple comorbidities and are considered to further enhance the demerits. Thus, in surgical treatment of the elderly, balancing becomes more important and more difficult. There are some possible approaches to decrease demerits of lung cancer surgery. One is surgical approach. Another is reducing the volume of lung parenchyma resected. I would like to outline these points, including recent studies. First of all, I would like to talk about surgical approach. For the past 2 decades, thoracic surgeons have been working to less invasive approaches. The figure on the right shows the video-assisted thoracoscopic approach called the VATS. As you can see, the surgical incision is getting smaller in the order of thoracotomy, mini thoracotomy, and VATS. The advantage of VATS lies on sparing of the respiratory muscles. This slide shows a study about post-operative pulmonary complication. Table of left side shows logistic regression analysis of pulmonary complication. VATS reduces risk of pulmonary complication by 20% compared to open approach. The bar graph of the right shows the frequency of pulmonary complications by surgical approach. As you can see, the reduction in pulmonary complication in the VATS group is more emphasized in patients with severe respiratory dysfunction. This result indicates that minimally invasive surgery might improve perioperative outcomes in elderly patients with high comorbidity. Here, I would like to introduce a robot-assisted surgery, RATS. The photos on the slide show the Da Vinci Xi system used at the University of Tsukuba Hospital, which consists of 3 parts: a patient cart, a vision cart, and surgeon console. RATS has several advantages compared to VATS. This system enables to perform procedure under clear 3D high-resolution view, and Da Vinci instruments have wrist allowing for more complex movement. The motion scale function allows to manipulate more precisely, and remote center technology can minimize stress on the chest wall during manipulation. Regarding issues and questions of RATS, I listed 3 points: cost, lack of tactile sensation, and the question about its advantage over VATS. First, cost is an obvious issue. The price of the Da Vinci Xi in Japan is about 300 million yen. The entry of new robots into the market is expected to induce price competition, resulting in lower prices. Regarding lack of tactile sensation, this might be attributable to intraoperative catastrophe. In US, 1.9% of RATS experienced in intraoperative catastrophe, such as intraoperative hemorrhage. More recently, surgical robot with tactile feedback technology is being developed in Japan. We hope this technology will reduce the number of the intraoperative catastrophe. In terms of the advantage of RATS over VATS, there are some results, such as its usefulness in hilar node dissection and a slight improvement of QOL. We will have to continue to verify this question in conjunction with advances in surgical robotic technology. Now let's move on to the second point. First, I will explain the surgical procedure for lung cancer. The figure on the left is an illustration of the lung. There is a nodule of lung cancer in the upper lobe of the right lung, marked in red on the slide. To resect this lesion, 3 different procedures were illustrated on this slide, namely lobectomy, segmentectomy, and partial resection. Partial resection is also called as wedge resection. The standard surgical procedure for lung cancer is lobectomy and mediastinal lymph node dissection. Segmentectomy and wedge resection were collectively called a sublobar resection. That enabled to preserve more lung parenchyma than lobectomy. A randomized clinical trial was conducted in Japan and North America to evaluate the role of sublobar resection for early lung cancer with tumor 2 centimeters or less in diameter. Wedge resection was excluded in JCOG study, but accepted in North American study. In both studies, sublobar resection showed comparable relapse and disease-free survival compared to lobectomy. In subset analysis of both these studies showed a consistent trend toward better outcomes with sublobar resection in the elderly. This suggests that reduction in resected lung parenchyma may be beneficial in the elderly. In summary, some possibilities for surgical treatment of lung cancer in the elderly have been reported, namely minimally invasive approach and sublobar resection. However, many questions remain to be answered, and further research is needed. Thank you very much. Okay. The next presenter is Dr. Kiyotaka Nemoto. The presentation is entitled Cancer and Dementia in Aging Population. Dr. Nemoto, please.
Good morning, everyone. I'm a psychiatrist from the University of Tsukuba. And then, since I'm a psychiatrist, I'd like to talk about dementia mainly. But the topic of this session is cancer. So we'd like to think about how aging will affect cancer also. So just last month, the Cabinet Office of Japan announced the recent population of Japan. As of October 2022, we have 124 million people, but the population of elderly, which means 65 years or older, is 36 million. That is 29% of the whole population. So as the topic of the session says, super age society. We really are in the super age society. And then the simulation shows that the rate would rise to 35% in 2040. It's only 20 years away. So we will have many issues about aging. So what the aging brings is the increase of the prevalence of dementia. And then maybe this is one take-home message. And then the rule of thumb is when people get 75 years old, around 5% of people will get dementia. And then when they get 80, and then the prevalence will be double. So I always remember that 5% at 75, and then when people get 5 years old, and then the rate will be double. So at the age of 85, the prevalence will be 20%, and then at the 90, almost 40% will have dementia. And when we think of the people or people having cancer, the same thing can happen. I'm interested, just Dr. Ichimura, but this is the graph of all cancers. And then, so aging is also risk factor for cancer. At the age of 70 to 74 years old, around 2.5% of male have cancer and 1% of female have cancer. And then as you see, the older people get, the more likely the people will have cancer. So we can say that the older one gets, the more likely one will suffer from cancer, and also the more likely one will suffer from dementia. So as a medical staff, we need to pay more attention to dementia. This slide shows the classification of dementia, and then it's almost the same all over the world. It's universally, basically universally. When we see people having dementia, half of them have Alzheimer's disease. So if you want to be a good doctor, you should say, okay, we need to think of Alzheimer's disease first, then because they will have Alzheimer's disease over 50%. And then 20% will have vascular dementia. It's dementia due to stroke or other reasons. And then 20% of people will have dementia with Lewy bodies. And then the 10% is other. So maybe we can focus on Alzheimer's disease first. And then, so let's think of the symptoms the Alzheimer's disease patient has. First, they have the memory problems, such as regularly forgetting recent events. And then when people get more demented, they forget places, names, and faces. But the very, very early symptoms of dementia is forgetting the future events. So we need to be careful, if we forget the future events, we need to be careful or be worried about having dementia. And also, the patient of the Alzheimer's disease tend to ask questions repetitively. Yeah. So in my case, the patient come to my clinic, and then the patient tell me the very, very same episode repeatedly, and then that's the sign that I need to worry that the patient might have dementia. And also, they have problems with executive functions, which means they have difficulties with tasks and activities that require organization and planning. The planning includes like cooking or planning for travel or those kind of things. And also, they become confused in unfamiliar environments. And when I say unfamiliar environments, that includes the admission to the hospital. You know, when people get admitted to the hospital, they are put in the very, very, different situations, and then they are easily confused, and then bring many problems. And also, many patients have difficulty finding the right words. So it's like, something is tip of the tongue, but they cannot clearly say what they want to say. And also, they have difficulty with numbers and handling money in shops. And we can imagine easily about this problem. If we travel abroad, and then if we don't understand the language of that country, when we go to the shop and then pay something, we tend to use the largest bill, right? Like maybe if 10 years ago I went to Hungary, and then people, I don't understand their word at all, and then so I always use the largest bill, and then so I get many changes. The same things happen with the dementia patient. Like even if they are in Japan, they always pay 1万yen, 10,000 bill, and so they have many changes. And also they tend to become more withdrawn or anxious. Yeah. 20 years ago, we didn't have any biomarkers to detect dementia, but now we have more biomarkers. Like it's like dementia, and then now we know that the amyloid beta is deposited in brain, and then now we have amyloid PET, which detects the deposition of amyloid plaque in the brain. And then last month, a pharmaceutical company released the medication which decreases the amyloid. And also we know that by seeing the MRI, we get the brain shrinks with the Alzheimer's disease. And also we developed a software which detects the atrophy of hippocampus, which is the main center of dementia. So as a conclusion, we will see more people with dementia in aging society. So we need to keep in mind the possibility of dementia when we see elderly patients. So several biomarkers help clinicians to diagnose dementia in its early phase. And if you are concerned about the patient's cognitive function, please consult a neurologist or psychiatrist. Thank you for your attention.
Thank you, Dr. Nemoto. The next presenter is Toshio Suzuki, Dr. Toshio Suzuki. His presentation is entitled Pharmacotherapy for Elderly Cancer Patients. Okay, so Dr. Suzuki, please.
Good morning. My name is Toshio Suzuki from the medical department of medical oncology from Tsukuba University. And I'm now 40 years old and in the Society of Super Age Society in Japan. And I might be a very rare population now. But today I'm going to talk about the pharmacotherapy for elderly cancer patients. So, this is my COI. So first, let me talk about the relationship between functional result in multiple vital organs and aging. And physiological function declines with age, even in the absence of the disease. And the person becomes vulnerable when the level of physiological function declines below that required to maintain daily lives and becomes frail. when it declines to a level very sufficient to maintain vital activities at rest. And multimorbidity is a common problem in aged population with a wide range of individuals and the societal consequences. The important patterns of multimorbidity include cardiovascular and metabolic and lung disease, as Dr. Hara said. And the number of diseases per patient, here's a, please look at the right figure, and here is the number of the diseases per patient. And the number of diseases per patient increases with ages, as you expected, and around half of those aged 75 or over have 3 or 4 diseases. And geriatric syndromes is a term used to describe a group of common health conditions in older people that do not fit into discrete disease categories. And these conditions include frailty and functional limitation, and falls, depression, and performance, and malnutrition, and cognitive impairment, as Dr. Nemeth said. And collectively, the geriatric syndromes arise from a complex interplay between age-related physiological changes and chronic disease and functional stresses in older adults. And each interacts with the other, and often the syndromes occur. Pharmacy, which is associated with significant consequences such as adverse effects and medication non-adherence or drug-drug or drug-disease interactions, and increased risk of geriatric syndromes. And in particular, the rate of adverse drug reactions increased dramatically when the number of medications increased 6 or more. So how can we find elderly patients who are good candidates for cancer therapy? And a comprehensive geriatric assessment was first introduced into clinical practice in the 1970s. And since then, a number of published studies have supported its value in both geriatric and oncologic settings. And its cornerstone is functional status here, and which together with comorbidities and geriatric syndromes identifies frail and vulnerable patients. Moreover, disabilities in ADLs and instrumental ADLs predict mortality in elderly people and add information to ECOG performance status. The Vulnerable Elders Survey 13, BEST 13, is a 13-item function-based scoring system that considers age and self-rated health, limitations in physical function, and functional disabilities, and provides a simple test that is clinically relevant for identifying older people with increased degree of vulnerability. And vulnerable patients are at 4.24 greater risk of dying during following 2 years. BEST 13 is highly sensitive and highly predictive for identifying impaired functional status. And cancer patients may benefit from comprehensive and multi-step management depicted in this figure. The method we propose here, considering previous reports, include directly observed physical performance and BEST 13, and cognitive screening, and targeted questions about syndromes and geriatric measures. The remainder of the data needed to stratify elderly to stage their aging are derived from routine clinical history and examination, and such as comorbidity or performance. And by this stratification, elderly patients should be divided into 3 groups: healthy and vulnerable and frail. And for the healthy patients, for the healthy elderly patients, the standard chemotherapy should be prescribed. But for the vulnerable patients, for the vulnerable elderly patients, we should consider less intensive chemotherapy. And for frail patients, we should consider best supportive care. So before moving on to the next topic, let me present a case of the 71-year-old carcinosarcoma patient with a good performance status, but who died of a treatment-related death caused by chemotherapy. He was introduced standard chemotherapy. Yeah, standard chemotherapy here, but soon suffered from neutropenic fever. and died as a result. And probably many clinicians have the same experience as this. So what can we learn from this case? That he had a good performance status. And there is one very interesting report in relation to this case. And the left figure illustrates the treatment-related mortality, TRM, according to age at diagnosis. The risk for TRM significantly increased with age as expected. And the right figure shows the prognostic factor analysis. As expected, poor PS, poor performance status patients resulted in high TRM, right? Treatment-related mortality rate. On the other hand, we also have to pay attention to elderly patients who show good PS here. Of note, patients over 50 years old with good performance status, good PS, had a relatively high TRM rate. So this result warned us that we have to consider not only performance status or PS, but also aging when we determine the regimen of the chemotherapy. So one key explanation for this phenomenon is a decrease in red bone marrow in the elderly. So myelotoxicity is severe in the elderly, and we have to take great care in determining the regimen of or chemotherapy doses for elderly patients. So another reason why elderly patients show high treatment-related mortality would be the level of their immune function. So the effects of aging on immune system are manifest at multiple levels that include reduced production of B and T cells, and NK cells, and bone and thymus, and diminished function of mature lymphocytes and secondary lymphoid tissues. So talking about renal function, so renal blood flow decreases by 10% for every 10 years after age 40. And I'm 40 years old. And individual differences in age-related changes in glomerular filtration values have been found to be significant. And this figure shows the length of the proximal tubules with age in autopsy cases of the sudden death. As you can see, there is an apparent shrinkage of the tubules after 50 years old. And for such condition, sometimes molecular target therapy such as VEGF inhibitor might induce severe impairment of the function. So let me sum up my presentation as follows. So first, the elderly is a heterogeneous population. And the second, while healthy elderly patients might be a good candidate for the standard therapy, vulnerable elderly patients should be started with less intensive chemotherapy. And frail patients should be treated with best supportive care. And third, tolerance to medical stresses are very impaired in the elderly. And finally, when we use the molecular targeted agents such as VEGF inhibitor, we should note that it could lead non-hematological toxicities, which is specific to diseases, agents, or patients. And that's all for today. And thank you for listening.
Thank you, Dr. Suzuki. Next presenter is Dr. Koshiro Nishikuni. The presentation is entitled Strategies for Healthy Brain Aging.
Good morning. I would like to thank everyone for the invitation and the warm reception. Also for supporting the exchange three young doctors from our hospital. Thank you very much. I will present about strategies for health brain aging, and especially how we can learn from Brazil, Japan exchange. When we examine current population pyramids, there is a strong contrast between Japan and Brazil. The Japanese pyramids has an inverted shape, reflecting a significant proportion of elder people. On the other hand, Brazil has an adult population at working age. However, When we project ahead to the year 2050, Brazil's population pyramids resemble Japan's today. So we can learn a lot with your history and experience. In this picture, we can see the brain atrophy that occur with aging. So white matter changes in the aging brain, leading to age-related cognitive decline. There are differences between Japanese and Western brain for language interpretation. The Westerns or Brazilian, we use only alphabets, phonetic characters localized in the left hemisphere. And Japanese use hiragana and katakana in their left brain, but use right brain to kanji or the image language. So Japanese brain is considered to be hybrids. It is said that their brain or your brains are actually more developed than Brazilian Westerns. So I want to learn more about your brain. There's paper, kanji and kana graphy in dementia, comparison other Japanese living in Japan and Brazil. In this context, we would like to do the study difference between Japanese, Western, and in case Brazilian Japanese brain. My suggestion to the study is brain function analyzed in language and cognitive function after stroke. A comparative study of Japanese and bilingual Brazilian Japanese is my proposal. This is our operation room equipment, microscope. With aging, the prevalence of brain cancer increases. Surgical treatments are often employed. The use of technological innovation like robotic microscope allows 3D dimension imaging by the use of specialized glasses. Here, the glasses for 3D visualization. Enhancing precision and safe surgery, avoiding brain lesion and cognitive impairment. After surgery, it is often necessary to do adjuvant radiotherapy. Proton therapy is a revolutionary treatment in field of oncology. Once there is no exit dose, avoiding damage to health tissue. There is no proton therapy in South America. Our young doctors came here at University of Tsukuba through the Sakura Science Plan for proton therapy training. Thanks for the support. We all know that physical activity is beneficial to health, but how does it work in memory? First, before beta amyloid oligomers play a crucial role in the progression of Alzheimer's disease. All of this process can result in synaptic dysfunction and loss of neurons. Exercise hormone irisin is produced in muscle during exercise. Brazilian recent research has found irisin appears to have a positive effect in synaptic and memory impairments in the hippocampus. Observed reduction in beta amyloid levels. So, exercise is an important activity for preventing dementia. Diet is important to brain health. An update review showing preventive effect of diet against dementia, showing Mediterranean diets as a positive impact. Many cultures have eating patterns similar to the Mediterranean diet, including Japan, washoku. Washoku is now in spotlight as a health diet all over the world. We make a project through Japanese cuisine to increase life expectancy in Brazil through the dissemination of health food. Sending our nutritionists to Kyushu University by support of JICA. And we developed Japanese menu as a healthful food. This is a picture taken by our nutritionist. And we published Japanese food recipe book in Japanese, Portuguese, and Spanish. Recent study demonstrate that having ikigai was associated with 36% lower risk of developing dementia. We visited the Japanese way of caring for the elderly at Sanlano Life Support, introduced by Professor Oneda, a rehabilitation center where the elders and their family members can feel reliable, safe, and comfortable. Based on the concept of ikigai, we make a ikigai longevity center in our hospital, a service focused in health aiding with preservation of functional capacity that guarantees independence of the individual. In conclusion, all these recommendations to prevent dementia and have a healthy brain aging should be put in effort during midlife. It is when you still can make effective changes in your brain. I hope we can learn more and more through Santa Cruz Tsukuba University Exchange. Thank you very much.
Thank you, Dr. Ichikuni. The next presenter is Dr. Sandra Hiroko Watanabe. The presentation is entitled Cancer in Brazil, a tumor that keeps on growing. Dr. Watanabe, please.
Morning. Thank you for this kind invitation. Actually, it's my first time here in Japan, and it's a great honor for me to be here with you in this meeting. Well, okay, today I'll talk about the scenery of cancer in Brazil, and it's still a tumor that keeps on growing. This is my agenda for today. And before talking about cancer itself, I would like to show you some demographic data. Brazil has a population of 203 million people, and our annual growth rate is 0.52%, and this rate is going lower in the last years. About 10% of our population have more than 65 years old, and 42% of all Brazilians lives in Southeast region where São Paulo is located. And what about cancer? According to Global Burden of Disease, in all of the world, there were 20 million new cancer cases in 2019. And over the past decade, 20% increase in this incidence. These are informations from INCA, that is the Brazilian Institute of Cancer, and the estimated incidence for 2023 and 2025 is 700,000 new cases, and 30% of them are skin cancer. Cancer in Brazil is the second cause of death. The first is the cardiovascular diseases, and 6 in 10 deaths by cancer are in patients with more than 60 years old, according to the Brazilian Society of Geriatrics. Here, the estimated new cases of cancer by gender in this year, of course, exclude the skin cancer. And for men, the most common cancer is for prostate, followed by colorectal, then trachea, bronchial, and lung, after stomach and oral cavity. The most common cancer in women are breast, after colorectal, then followed by uterus, then trachea, bronchial, and lungs, and at 5th place, the thyroid gland. Now I will show some papers about cancer in case. In this table, we can see the mortality and the comparison between these three groups, the native Japanese, the Japanese Brazilian, that is the Nikkei's, and native Brazilian. The group of native Brazilian have a lower mortality for stomach and colorectal cancer, but the native Japanese have a higher mortality for liver, gallbladder, and lung cancer. But on the other hand, the native Japanese have a lower mortality for prostate, breast, and brain cancer. This is a case country study among Nikkeis in São Paulo, and the authors found that the frequent consumption of beef increases risk of stomach cancer with an odds ratio of 4. But daily consumption of fruits was associated with a reduction of this risk. This is another study where the researchers found that Japanese Brazilian and Brazilian women have higher levels of estrogen and androgen hormones than Japanese. And these two groups, the Nikkeis and the Brazilian women, have more breast cancer than Japanese women. Here, the prevalence of precancerous skin lesions and non-melanoma skin cancer in Nikkeis in Bauru. Bauru is a medium-sized city in the state of São Paulo, a very hot, a very sunny place. And the prevalence in Bauru is 13%, comparing with the prevalence in Japan that is 0.7 to 5%. Now I'd like to contextualize the healthcare system in Brazil. 70% of the population depend on public health system that we call SUS. About 1/3 have private health insurance, mainly provided by the employers as a benefit. And in this year in Brazil, we have more than 500,000 medical doctors. We have 4,700 clinical oncologists, but we have less than 2,000 oncological surgeons. The Brazilian government spends 4 billion reais for the treatment of cancer, that is equivalent to 120 billion yens, and is distributed in this form: 77% for outpatients, 10% for inpatients, and 13% for surgeries. And this cost increases 400% in the last 2 years, because of the spends with chemo, radio, and immunotherapy. And in Brazil, the breast cancer has the highest macroeconomic costs. In Brazil, we have more private service than public units able to treat cancer, and it is not very well distributed. In São Paulo, we have more cancer centers than the rest of Brazil. And as the theme of this session is the present challenge and the future vision, I would like to share with you my point of view of the challenges that we are facing in Brazil now to treat cancer. First is the geographic contrast. The Southeast and South are richer, so we have, of course, better health assistance than the rest of Brazil. Second, there is no equality to access the treatment. Actually, we have a law in Brazil that says that every cancer patient has the right to be treated by SUS, by free, until 6 days of the diagnosis. But in reality, it does not occur. In some places of Brazil, the patients have difficulty included to access a simple medical appointment or simple exams like mammography. 95% of the new drugs approved in the last 10 years are not available in SUS. 75% of chemo, radio, and chemotherapy are funded by the government. And 15% of the patients with private health care assistance have their hospital admissions paid by the Brazilian government. And 68% of Brazilian radiotherapy services provide assistance to SUS. And at last, the increase of age population, that is also the same as you hear in Japan. So as President Nagata says, I think we have to design the future, and I hope we can find the solution for this challenge in the near future. Thank you very much. This is my contact, and I would like to invite all of you to know our hospital in Brazil. You will be very welcome. We will open you with open arms. Thank you so much.
Thank you. So now move on to the next part of the program. We will have 3 presenters from Santa Cruz Japanese Hospital who were invited to the University of the Tsukuba Hospital for a 3 weeks visiting program. They will talk about their experience in Japan and their thought about medical issues we are facing. In fact, the content of the presentation is left entirely up to them. So they can talk, they want to talk. So, okay, now let's get started. The first presenter is Dr. Tatiana Tanaka. Sorry. Dr. Tanaka, please.
Good morning. First of all, I'd like to thank University of Tsukuba and Santa Cruz Japanese Hospital for the opportunity to be here. I'm Tatiana Tanaka. I'm ophthalmologist and also coordinator of the ophthalmology department at Santa Cruz Japanese Hospital. So in this observational program, I could see many outpatients, and we see that the treatment that we're doing in Brazil is also the same. I could see also many ocular surgery, and our operating room and the equipment that we have in Santa Cruz Hospital is the same that you have here in University of Tsukuba. I really impressed with the research that you do in University of Tsukuba, that you do also the basic research and clinical research, which was very amazing. So something that I caught different that you do here in Japan is in Brazil, we do this mark, the doctor make this mark in front head of the patient before they go to the surgery to do the correct eye. And here in University of Tsukuba, you use artificial intelligence. So before the patient goes into the operating room, you take a photograph and then you compare if it's the correct patient. And also you use an iPad to do this, and they take a picture of the patient when he's lying down, and also compare if it's the correct eye according to the record data in the medical record. So you could be more precisely. And another thing is you use artificial intelligence in cataract surgery. We use lens to do the surgery, and you take a photo like this and compare it also with the medical records. And in Brazil, the doctor and the nurse do this manually. So in 2018, two doctors from University of Tsukuba went to Brazil, Doctors Hoshi and Dr. Okamoto, and was possible to carry out and work on collaborative international work, collaborative, and they did this paper. And so to make it possible with my training here, Dr. Hoshi organized 2 web meetings between the doctors of University of Tsukuba and also from Brazil, from University of São Paulo, and some doctors from Santa Cruz Japanese Hospital. And also, we have opportunity to talk with doctors from other parts of Japan, like Nagoya with Dr. Kaneko, and from Oita University with Dr. Satoku Nakano. So we are trying to compare between vitreous analysis in Brazil and Japan, the difference and similarities of 2 health centers and future direction. So in Japan, you develop the PCR strip that is made here and to analyze the ocular fluid. And it is a fantastic PCR because you can analyze also with small volume, fast test, and you do multiple agents. So you can diagnose the whole family from herpes virus, toxoplasmosis, syphilis, and HLV. We are trying to do another research about iron in human vitreous also. And in Brazil, we have the patient with this disease, a lot of patients with toxoplasmosis and syphilis that maybe you see less here, and you have this fantastic technology. So we are working out in doing a research with this subject. This photo represents our happiness to be in the end of a web meeting, and maybe we have the same ikigai, that is to do the research, carry out the research that we do, and make it possible to real life around the whole world. So I'd like to thank, and let's try to design the future together. Thank you so much.
Thank you, Dr. Tanaka. Thank you. And next presenter is Dr. Victor Ishii.
Good morning, everyone. First of all, I would like to thank to Hospital Santa Cruz for this opportunity and University of Tsukuba for receiving us so warmly. I'm Victor Ishii. I'm a doctor in Brazil, and I'm representing Hospital Santa Cruz, and I'm obstetrics and gynecology in Brazil. And here I am to present a report of my training outcomes and future issues. For general objectives, I'd like to promote and share experience between Japan and Brazil, since in Brazil we have a lot of distance of Japanese people there, and strain of times between Japanese community in Brazil in Hospital Santa Cruz and University of Tsukuba Hospital too. For my personal objectives, I'd like to acquire knowledge about healthcare in Japan, especially in my working area, that's in gynecology and obstetrics, and network for future projects too. I was very lucky to be able to know 3 different areas from gynecology and obstetrics. So the first area was the first week, it was in gynecology. And the most interesting thing that I saw in the first week was the application of robotic surgery in Da Vinci in gynecology, especially in oncologic patients. Studies suggest that robotic-assisted gynecology surgery can be safely performed in centers with experienced surgeons and had perioperative outcomes equivalent to laparoscopy and improved outcomes compared with laparotomy. And addition to that, we have like the a 3D vision of the surgery too, compared to laparoscopy. So this is a photograph of Da Vinci, and I could be able to see in real surgery with Da Vinci in the first week. In the second week, I was able to observe obstetrics here in Tsukuba. And the most impressive thing that I saw that I didn't even see in Brazil, it was the use of Alexis in cesarean sections. Some studies suggest that the use of Alexis could decrease surgical site infections. So that it was very interesting to see. And that Alexis is like a retractor, abdominal retractor, and suggests to be decreased like surgical site infections. So that was very interesting to see that we don't use like any retractors in Brazil. And I never seen this in Brazil too. So that was very interesting. In the third week, I was able to observe the reproduction department. And the most impressive thing, not only in reproduction department, but in the other departments, was the ability of here in University of Tsukuba to provide multiple treatments and diagnosis too, especially in outpatients. So in the same time that you see the patient in the outpatient, you could use several tools to perform the diagnosis, like ultrasound and colposcopy. And for this, for example, I was able to observe a patient with diagnosis of infertility to do it at the same time that she came to the hospital, hysterosalpingography. So that's a picture, for example, of hysterosalpingography, and they did that, and I could be able to observe that. And for general learning, I am a descendant of Japanese in Brazil. So my parents always tell me that Japanese people, there are like two things that's very important for I to be learning. And I could see in real here, especially in the hospital. So it's the punctuality in medical care and the maximum respect about the patient care too. So that's my parents always taught me that the Japanese always are like that. And I could be able to see here in Japan too, especially in the hospital. And that's it. Thank you very much.
Thank you, Dr. Ishii. So the last presenter is Dr. Vinicius Ruder Diaz. So Dr. Diaz, please.
Hi, everyone, and morning. I want to start thanking the University of Tsukuba and the Santa Cruz Hospital for the opportunity to be here. I'm going to talk about my training outcomes in this period I had here. So at first, a little introduce from myself. I graduated in medical school in 2008 and had my general surgery medical residency at 2011 and my thoracic surgery residence in 2014 and got my PhD degree at 2019. And at first, my initial impressions before I arrived here, I was without many expectations, primarily because I've made some Google search and I couldn't find many information about the thoracic surgery service here. So I found out some published studies, but not information about how it works. And so I had no preview schedule and when I arrived here, I got a little bit anxious, I had to confess. But after getting here, I had a very good reception, especially by the thoracic surgery group. I could see they had a big effort to communicate and help me in anything that I wanted. I could learn about the thoracic surgery department organization. And so I started my observership program here. Basically, I did some patients conference. I could see a lot of surgeries, bronchoscopies, and we had some case discussions. By doing it, I could see the mainly difference between Brazil and Japan in about surgeries, especially thoracic surgeries. I could see new approaches on surgeries that probably I'm gonna use in my work experience. I could see that technologies that are not available, at least in my service, especially the robotic surgery, and could observe knowledge from their great experience in lung cancer. There is a subject that interests me a lot. So my conclusions, I think this program exceeded my expectation, far from the most. And I see the thoracic service here as a model to follow, especially by the big team effort, the great passion on doing it, and the extreme care and skillful team they have. So I'm very grateful for the opportunity for being here, and I want to thank everyone for being here in Japan. Thank you.
Okay. Now we had a plan to move on to the Q&A session, but it is already past the scheduled time, so you can ask question later as through our discussion. Then, okay. Now I'd like to ask Mr. Renato Ishikawa, President of Board, Santa Cruz Japanese Hospital, to give a closing remark. Mr. Ishikawa, please take the podium.
Good morning, everyone. I'd like to, first of all, say, dear Professor Kyosuke Nagata, who left now, Honorable President of the University of Tsukuba, Professor Akira Hara, Vice President for Tsukuba, and a distinguished director for University of Tsukuba Hospital, Osamu Oneda, Professor Fukushigi, Professor Hiramatsu, we're still waiting for you in Brazil. And ladies and gentlemen, good morning, everyone. First of all, I'd like to congratulate all of you for this wonderful event that promotes science, technology, friendship, and cooperation for the well-being in society as a whole. And offer you my profound thanks for the invitation to this historical commemoration, one that is also so important for education, both Japan and the world. I'm especially happy to be here today to congratulate University of Tsukuba for this 2nd anniversary of its founding. I also want to thank you very warmly for the partnership cooperation that we have maintained throughout of the years between University of Tsukuba and the Santa Cruz Japanese Hospital in São Paulo. This consistent exchange of information and inspiration between our institutions has always given us profound satisfaction. The exchange of experience, knowledge, discovery, enriches and strengthens us all both countries. Today, cancer is one of the world's big health problems, shared by both Japan and Brazil. Thus, medicine cannot spare no effort to combating it. Due to the importance of cancer, the Santa Cruz Japanese Hospital has inaugurated its cancer treatment center, which is equipped with state-of-the-art radiotherapy and brachytherapy technologies. Thus, we hope and will be able to exchange experience and practice also in area oncology, creating ever closer bonds between us. I am especially grateful to you for the warm welcome given to our doctors Tatiana Tanaka, Vinicio Diaz, and Victor Ishii. I am certain that the learning experience they have received from you will be a great importance to our hospital and our treatment for our patients. Once again, I want to express our deep thanks for this event and its role in promoting development of scientific knowledge and practice, and of equal importance, probably it's most important, our friendship and cooperation for the well-being of society. It will be great satisfaction to be here with you for these 2 days. I like you convey to Professor Nagata to see we'll be able to welcome you São Paulo again to visit our hospital. Thank you very much.
Thank you, Mr. Ishikawa. Next, I would like to ask Dr. Yuji Hiramatsu, Vice Director of the University of Tsukuba Hospital, to give a closing remark. Dr. Hiramatsu, please.
As a Chief of International Medical Center at the University of Tsukuba Hospital, thank you to everyone who attended this important international session. As the world moves toward aging society, we had an informative presentation and discussions over cancer care in the near future. From various angles and from the standpoints and environments of 2 countries, Brazil and Japan, which are far but near each other. Dr. Ichimura, Dr. Nemoto, and Dr. Suzuki gave us expert commentary on the current situation and future issues of Japan, while Dr. Nishikuni and Dr. Sandra Watanabe presented the current similar situation and their own challenges in Brazil. In addition, 3 young doctors who are participating in training in Tsukuba Hospital also gave us their nice experiences here. And I believe that we were able to approach the issues that need to be addressed by the 2 countries and the entire world. Although this Santa Cruz Japanese session was held face-to-face for the first time in 4 years due to the pandemic, I believe this today's informative discussions will once again stimulate medical exchanges between the 2 institutions. I'd like to thank Mr. Renato Ishikawa for his warm comments, which deepened the significance of today's session. I'd like to conclude by wishing our guests from Santa Cruz a fruitful stay in Tsukuba and Japan. And I hope that we, the University of Tsukuba Hospital, will soon be able to visit Santa Cruz and São Paulo again. And I personally wish to visit Amazon for fishing. Yeah. Thank you very much for your kind attention today. Thank you very much.
Thank you, Dr. Hiramatsu. I hope that this session will be the first step in addressing the issues raised in this session I also hope that we can continue to have opportunity to share and discuss issues in future. Thank you very much for your attention today. I am closing this session very punctually. Now, thank you. Thank you for all of that. Okay, so we will see the video, short video from the Santa Cruz Hospital. Thank you.
Great.
1939年に創設されたサンタクルス日本病院は、1908年に移民としてブラジルに到着した日本人に医療を提供することを目的として誕生しました。日本政府、日本の皇室、そして移民たちの協力によって建設されたこの病院は、現在に至るまでブラジル社会全体にホスピタリティと温かみのある伝統的なおもてなし、サンタクルス流のおもてなしを提供しています。企業や学術機関、特に日本の機関との強固なパートナーシップにより、サンタクルス日本病院は患者の病態の診断と最先端の治療の実践、そして技術を吸収することが可能となっています。当院には一般手術センターと眼科専門手術センターの2つの手術センターがあります。170床の入院病床のほか、ICU、集中治療室、検査室と画像診断センターを備え、幅広い専門分野で高度な医療を提供しております。救急部門では一般、整形外科、眼科の3つの部門があり、さまざまな緊急事態に速やかに対応することができます。さらに、当院には専門スタッフを要するがんセンターがあり、骨髄移植の実施のほか、最新の放射線治療機器を備え、がん患者に最善の医療を提供しております。内科、泌尿器科、整形外科、神経科、婦人科、眼科、人工透析センターなど幅広い専門外来を備えており、診察、診断、治療など万全の医療サービスを提供しております。ぜひ当院へご来院ください。サンタクルス日本病院、高度な技術を備えた温かみのある人間的な医療サービスを提供します。
Thank you for the video. Okay. Okay, so now closing. Okay. Thank you.